So I'd like to present our experience with treatment of difficult vascular malformations. So as I said, it's a combined game of Department of Radiology and Department of Plastic Surgery. So I'll be talking about combined therapeutic embolization with immediate surgical ablation for difficult vascular malformations, our experience. And this is my radiology colleague, Dr. Raghunandan, who has been instrumental, and we have been working together for planning and for treatment of these patients. Now, what is the layout of this talk? I'll brief you about the introduction to vascular malformations. What are vascular malformations? I'll talk about the classification of vascular malformations. I'll tell about the clinical assessment of vascular malformations. What are the various treatment options for vascular malformations? Then there is one drug, bleomycin. What is the role of bleomycin in vascular malformations? And then I'm going to tell about the indications of combined approach that I'm talking about, in which we do preoperative embolization and then followed by immediate surgery in these patients. A little bit about the technique and then the clinical results. So what are vascular malformations? Vascular malformations are developmental abnormalities from vascular tumors or hemangiomas because they have different causes, growth patterns, treatments and outcomes. Now there is a primary distinction between a vascular tumor which grows by cellular hypoplasia and a vascular malformation which represents a localized defect in vascular morphogenesis. Now what I have observed even in doctors, even in practitioners, there is a lot of confusion regarding the terminology. Basically, there is a broad group of vascular anomalies, and within that broad group, we have got two subgroups. One is hemangioma, the other is vascular malformation. So, what I've seen is, see these hemangiomas, they don't appear at birth. They are seen some time after birth, and then they have a different natural history. Whereas vascular malformations have altogether a different natural history. You will never find a hemangioma in an adult patient because hemangiomas don't stay up to that time. But then there is a lot of confusion in the terminology, which is why I have put this slide. So basically it's hemangioma on one side and vascular malformations on the other side. In this presentation, I'll be talking about vascular malformation and a little bit about hemangioma also. Now, what are the clinical differences between a hemangioma and vascular malformation? If we talk about hemangioma, a hemangioma may or may not be present at birth, whereas vascular malformations are always present at birth. This history is very obvious and very apparent given by the parents, especially the mother. When she notices a lesion on the child, she immediately can give you the history, whether it is present since birth or whether it is present a little after birth. Now, what about the natural history of hemangioma? They involute spontaneously with age. They have a rapid postnatal growth and involution. So hemangiomas, they are observed a little time after birth. Then in the first year or maybe the second year, they grow very fast in size and then they start involuting. And by the age of 4 to 5 years, the natural history is complete. That is about hemangioma. What about vascular malformations? Hemangiomas are tumors of the vessel wall. There is endothelial hyperplasia. But in a vascular malformation, there is no tumor. There is a deformed vascular wall which expands with age, keeps on increasing with age. So a vascular malformation will grow proportionately with the child. As the child will grow, the vascular malformation will grow, and it has the propensity to grow till adult or even late adult age groups. vascular malformations have no gender predilection. They found that females are more commonly affected, and hemangiomas are basically true benign neoplasms of endothelial cells, whereas on the contrary, the vascular malformations are localized defects of vascular morphogenesis that results in the formation of abnormal, tortuous and enlarged vascular channels. Now, when we come about vascular malformations, the vascular malformations can be categorized based upon their hemodynamic features and also based upon their histological features. Now, vascular malformation can be of many types, and these are the points which differentiate the vascular malformations. Now, the vascular malformations, depending upon the vascularity, it could be a simple lesion, which is a low flow lesion. It could be venous. It could be lymphatic, depending upon which vascular channel is being involved. Then it could be a high flow vascular malformation. High flow vascular malformations obviously are arterial. And then we can have combined lesions in which we have a little component of each of these, in which we can have arteriovenous vascular malformation, in which the artery and the vein is involved, or it could be a lymphovenous malformation in which the vein and the lymphatics are involved. So these are the broad categories of these vascular malformations, and it is important to understand which category of the patient that we are dealing with, because as soon as we understand the category, we are able to understand what would be the natural history of that lesion and what treatment we have to do for that lesion. It becomes very clear. It could be other combinations also. So as I said, the classification of vascular abnormalities can help the practitioner to establish the correct diagnosis. And accurate diagnosis is essential because treatments vary according to the nature of the lesion. If, for example, there is a vascular malformation, then you don't have to wait, because you know it's not going to resolve spontaneously. Some treatment has to be given. If it is a hemangioma, then you know it has got a natural history. After some time, by the age of 4 to 5 years, the hemangiomas will spontaneously go away. But obviously there are certain indications and in certain cases the hemangiomas that we have to go for intervention in hemangioma and not wait for that. So the diagnosis of vascular malformations is based on clinical assessment, radiographic assessment, histopathological examination, and laboratory examinations are done. Clinical assessment, I've already emphasized. These questions are simple for the residents. You ask these questions and you get the answers, and then you can make a diagnosis. Present at birth, rapid proliferation, involution present, lesions present in adulthood. So these could be the diagnosis. As William Osler said, listen to your patient, he's telling you the diagnosis. Now, radiographic assessment is very important, and radiographic assessment is one of the main assessments in patient with vascular malformations. The mainstay of investigation is the magnetic resonance imaging, and we get the magnetic resonance imaging for so many reasons. Magnetic resonance imaging tells you the size of the lesion. Magnetic resonance imaging tells you the extent of the lesion. Magnetic resonance imaging, it tells you the approach to the lesion. It tells you how to access that lesion. It tells you about the surgical planes of the lesion. It tells you the preoperative size of the lesion. And it also tells you about the quality of the lesion. If there is a venous vascular malformation, MRI can tell you that. If it is arterial, MRI can tell you. If you can see phlebolytics, it's a characteristic of a venous vascular malformation. So magnetic resonance imaging is a very important investigation for both planning and treatment of these vascular malformations. Angiography obviously is there. It tells you about the size of the feeders, the vessels which are feeding that vascular malformation. It tells you about the length of the feeders. It tells you about the thickness of the feeders, and it gives you a broad overview of the problem that you are facing. If you can see the number of feeders, maybe you can go in beforehand and ligate these feeders, and that way you can tackle the problem beforehand. So angiography is very important. You can see here the dilated tortuous vessels which are seen. That is the radiological assessment of oral vascular lesions, not only oral, where in the body. And computed tomography is important not only in knowing the size and the extent of the lesion, but it also tells you about the involvement of the adjacent structures. What is the bone like? Is it compressing the bone? What about the vessel? What the nerves? Computed tomography is a very important for these. The flow of the lesion, the distance of the lesion from the surface. First, small, even located on the face, even if it is not causing a actual problem, it complains of operation, the picture. What about that? Critical is important, but functional problems are also. If the lesion becomes large, it can cause discomfort, it can cause compression of the embryonic structures, and so there are so many problems which can be related to these lesions. Oral cavity, vascular malformation cause discomfort and potentially serious clinical problems. Vascular malformation is big in the oral cavity. Then it can cause recurrent hemorrhage because of damage by the teeth. It can be because of lesion, or you can have pain and discomfort following mastication. Problem can based on research data. Targeted management should depend on the correct recognition of these two categories, hemangiomas and vascular malformations, and there's so many treatment modalities which are available. For example, steroids are effective for proliferating hemangiomas, but not effective for involuted hemangiomas and vascular malformations. So therefore, correct differential diagnosis is critical to appropriate and individualized treatment of these lesions. The choice of different modalities is dependent on the phases, site, location, extent and depth of the lesions. If you have a small to middle-sized venous malformation, the first line therapy is intralesional sodium tetradecyl sulfate. Now this is a sclerosing agent, and what it does is it will cause inflammation of the vessel walls, and therefore it will lead to fibrosis and shrinking of the lesion. Now the second line therapy is a drug which is bleomycin. Now bleomycin has proved very effective in the last years, and it is basically an anti-cancer drug, and there are so many mechanisms of action which I will detail briefly. So bleomycin is the second line therapy for these lesions if it is refractory to intralesional tetradecyl sulfate. If it is a large size venous malformation, then we might have to use combined bleomycin sclerotherapy with surgery. Now for arteriovenous malformations, the treatment of choice is embolization, plain embolization or embolization with surgery, depending upon the size of the lesion. A lot of lesions respond to embolizations and no surgery is required. But if the lesion is particularly large, then basically it has to be combined with surgery. Now, what are the treatment options for vascular malformations? This is the whole list of treatments which are there for vascular malformations, and there are others also, but these are the main ones. There could be laser treatment, there could be transmucosal thermocoagulation, surgery obviously is there, sclerotherapy by cetrol, sclerotherapy by bleomycin, embolization, liquid nitrogen cryotherapy, and lastly, it could be a combined multi-modality treatment for which I'll be sharing my experience and results. Coming briefly onto the laser treatment, laser therapy is a mainstay in the management of mucosal vascular malformations nowadays with different wavelengths, different indication parameters and application procedures. They can be used in photocoagulation, vaporization or excision procedures. And the most common lasers are ND-YAG laser, KTP laser and diode laser. And laser therapy is a very important modality for treatment of these lesions. It is good as regards the aesthesis, as regards the cosmesis, and if the lesion is suitable, laser therapy is very effective in the treatment of this vascular malformation. It doesn't cause any scarring. So that is a very good treatment. Now the advantages is it eliminates the vascular lesion without significant hemorrhage. It causes disinfection of the surgical wound. No need for sutures. As I said, less scarring. If you do surgery, there is going to be scarring. So laser, there is less scarring and less post-operative complications in comparison with conventional surgery. What are the disadvantages? The potential risks of laser therapy include thermal injury to nerves, skin scarring due to laser treatments of superficial lesions, and during the operation while performing the incision, some fume released from vaporization of epithelium may provoke stress or discomfort, particularly if it is a large lesion. And then there is one more modality which is TMT. I'll not go into the detail because we don't do that. It is also affected by systemic pathologies, and these are the results of TMT. Now coming on to sclerotherapy briefly. Now sclerotherapy consists of direct intralesional injection of a sclerosing agent that causes the destruction of endothelial surfaces with subsequent thrombosis leading to intimal fibrosis and obliteration of the vessel lumen. This procedure has been largely and successfully used for the treatment of symptomatic venous malformations and can be considered the treatment of choice for small and middle-sized superficial and deep venous malformations of the oromaxillofacial and cervical regions. So sclerotherapy is the keystone management for treatment of vascular malformations over last so many years, and it still is mainstay of management of these vascular malformations.
He was taking class for MD students.
I talked about sclerotherapy.
Like that,
Sclerotherapy. Bleomycin, it's basically bleomycin sulfate of the drug in one vial, and these are the other constituents of the vial: sodium hydroxide and sulfuric acid. So it is a mixture of cytotoxic glycopeptides, antibiotics, isolated from a strain of Streptomyces. Now, what is the mechanism of action of bleomycin? The mechanism primarily is unknown, but it is said that it inhibits the DNA synthesis and it also inhibits the protein synthesis once injected into the malformation. And the double strand of the DNA breaks. So that is how it works in taking care of these malformations, which are very difficult. A little bit about the absorption. Can be given intramuscular, subcutaneous, intrapleural or intralesional. Now, what are the indications of bleomycin? It is used for extensive vascular malformations. As soon as we get an extensive vascular malformation, we don't take the patient for surgery. We put him on these sclerosants. And the advantage of these sclerosants is that it helps to shrink the lesion, it helps to reduce the vascularity of the lesion, and it makes the work of the surgeon less challenging and less stressful, because it is very difficult to put your knife in these lesions because they bleed like hell when you operate them in the OT without any bleomycin or without any sclerosants. Sometimes bleomycin works wonders and it helps in regression of the lesion to as much as 60, 70, maybe 80% regression of the lesion can be done by bleomycin. So it is good for extensive vascular malformations. It is good for deep-seated head-neck vascular malformations which are difficult to access by surgical approach. And it is good for long-standing extremity vascular malformations. So it is a great adjunct to surgical treatment, bleomycin sclerotherapy. Now what is the method of treatment? Now this is not done on an OPD basis. The patient is admitted for observation. The dose of the bleomycin is 0.5 milligram to 1 milligram per kg body weight. The drug is diluted in saline. Antibiotics and analgesics are given after the injection. And the patient is kept on observation for 24 hours after giving bleomycin because sometimes it can cause pulmonary complications. So we always admit and observe the patient 24 hours after giving bleomycin. Usually 3 to 4 injections are given at an interval of 3 to 4 weeks depending upon the response. If the response is good, we can give more injections, but if the response is not good, then we can think of any alternative treatments. But usually in 70 to 80% of patients, the response is good with bleomycin. Rule out pregnancy, obviously. Some results here with bleomycin, you can see here. Now this girl had a fairly extensive vascular malformation which was involving the whole left hemiface, it was involving the cheek area, it was involving the parotid area, it was involving the lips area. You can see here even intraorally there were huge lesions intraorally. It was going inside into the pterygopalatine fossa, into the retromolar area, and it was going into the palate. So it is very difficult to tackle surgically, obviously, because you can't just go in and excise it. It will just, she'll bleed to death on the table. So therefore, these are the candidates who need this kind of treatment, whether it's a bleomycin or a sclerotherapy. Sodium tetradecyl sulfate will not work in this situation. You need something like a bleomycin or some other drug for this, and you need many sittings for her. And this is the lesion, and this is the result after 4 sessions of intralesional bleomycin. Not much improvement, but still I have done 4 sessions of bleomycin and also done a lot of surgical resection by the facelift approach for the lip lesions, and she's still under treatment. This is a lesion in the lateral view. You can see here before and after treatment. Now let's talk about embolization. What is embolization, which is the main subject? What is embolization of vascular malformations? Embolization is defined as the therapeutic introduction of various substances into the circulation to occlude the vessels, either to arrest or to prevent hemorrhage, to devitalize a structure, tumor or organ by occluding its blood supply, and to reduce its flow, especially in a situation of arteriovenous malformations. Now, embolization may have 3 therapeutic goals. It could be preoperative as an adjunctive goal to chemotherapy or radiation therapy. It could be the definitive treatment. It could be an accurative goal, which is performed in cases of aneurysms, arteriovenous fistulae, arteriovenous malformations, and traumatic bleeding. Or it could be palliative when the lesion is, if the patient is too old and there are so many multisystemic problems, then it can be a palliative goal. Now let's see what are the embolizing agents that are being used. The radiology colleagues would be knowing more about that. These are the agents which are used. Polyvinyl alcohol foam particles. It could be embosphere. There's a host of agents which have been used for intravascular embolization. Histoacryl glue, liquid embolic system, coils, microspheres, balloons, and many others. but the radiology colleagues, they have been using lipidol with glue, if I'm right, for doing the therapeutic embolization. Now these are the diagrams and the different agents which are there. This is how a coil looks like. This is the liquid embolic system. This is the gel foams, which are very frequently used in many centers, and also the embospheres. It all depends upon the indications of a particular malformation. It depends upon the choice and the comfort level of the radiologist of which agent to use for these embolization procedures. Now, what is the disadvantage of embolization? The disadvantage is there is a risk of material reaching cranial cavity via external and internal carotid arteries, and therefore there is a need of an experienced radiologist in order to perform this procedure. Now I'll go to some patients. Now this is a clinical picture of a patient showing a deep-seated palatal vascular malformation. You can see here. So this is a deep-seated palatal vascular malformation on the right side, which was found unsuitable for surgical excision. It was treated by 3 sessions of intralesional bleomycin, resulting in significant regression of the lesion. And somehow I have seen a lot of palatal vascular malformations coming here, and most of them, they are particularly in this particular area, and I think a lot of studies and a lot of research, a lot of time needs to be spent in really studying these lesions. Why are they being present here, and what are the different intricacies in the pathogenesis of these lesions? So this was treated by intralesional bleomycin, which resulted in significant regression of this lesion before and after. Now, what is therapeutic endovascular coiling? In therapeutic endovascular coiling, the embolization is done using selective arterial cannulation under imaging control. This is the purview of the Department of Radiology. The feeders are embolized with a mixture of cyanoacrylate glue and lipidol in different proportions. Lipidol is 4 and glue is 1, and I was talking to Dr. Raghunandan yesterday, and he said that the composition varies depending upon the indications and how far you have to send these materials inside the vascular system. Now, if we talk about the devascularization, how much it achieves 70 to 90% devascularization, and this can be achieved in 2 to 3 sittings, which is very good for us. And what medium is used? They're using a pro-grade microcatheter system for doing these embolizations. It can be done either under GA or LA, depending upon the response of the patient. If the patient is comfortable, you can do LA and you can do the puncture even in LA. GA is not required. And multiple sittings may be required depending upon the size of the lesion. Now this is the pro-grade microcatheter system, which is used for this procedure of therapeutic endovascular coiling, which is currently being used in the Department of Radiology here for performing these embolization procedures. I won't be able to tell you a lot of details about this, but it appears very sophisticated type of a thing, and there are so many anatomical features here. So what it does is that it is a microcatheter system. It is designed for therapeutic embolization and angiography in peripheral vessels. It gives control with ease of use. It has kink resistance and distal flexibility. There is a coaxial system which allows fast and smooth procedures through wire integration and easy microcatheter preparation. And there is a tungsten spiral coil in its 3-layer structure which protects the inner lumen integrity for smooth delivery of all types of embolic materials. And this is the pictures inside the radiology. You can see here the procedure is being carried out on left side and on the right side under imaging control. And this is the live images of how the catheter is introduced. The patient is lying supine. This is the catheter which is being introduced. If the lesion is on the left side, they introduce the catheter from the right side, and if the lesion is on the right side, the catheter is introduced from the left side. They put the catheter in the common femoral vessel, and from there they guide the catheter up towards the lesion. And everything is done under this imaging control. So that is therapeutic endovascular coiling. Now coming on to the surgical treatment. Surgical excision is usually considered to be the definitive treatment for both superficial and deeper lesions. And during operation, special care should be taken to preserve the various nerves in these cases and perform careful dissection with nerve monitoring and thorough hemostasis. Surgery is a little stressful because the lesion bleeds. It bleeds like hell, and you have to be, you have to warn the anesthetist before treating the lesion. You have to put 2 peripheral lines and start giving fluid so that the patient doesn't go into hypotension. And even then hypotension occurs, you have to arrange the blood, and you have to make sure it doesn't bleed too much. So a lot of planning is required while performing surgical excision, even after the patient have received sclerotherapy with bleomycin. And compound lesions should be initially treated with sclerotherapy to remove the superficial component and then followed with by surgical resection. Now the aim of the surgery is to remove the malformations for improvement of the contour and preserve the involved organs as much as possible for better function. Now what are the disadvantages of surgery? Attempts to excise large venous malformations usually cause significant morbidity and can cause significant scar formation. Therefore, surgical excision should be used for lesions that do not involve the significant muscle groups or bones and should only be performed by experienced persons. Despite successful removal in many cases, these lesions recur after surgery. It is very important to explain the patient because patients come with extensive malformation and it is not possible to excise the entire lesion. So what happens is we do 50%, maybe 80% or maybe 90% excision of the lesion, and the rest lesion remains there because it is just not possible to remove everything. Because if you remove everything, the shape, the face will become dephased, it will become out of shape. So you have to leave the lesion, and therefore the patients have to be explained that even after surgery, most of the lesion has been removed, but you have to come for follow-ups because of the residual lesion, and these patients come for follow-up, and whenever we see that the lesion is growing, we can again go in and put some more sclerotherapy and put some more surgery there. Now what is the combined multi-modality therapy? Sclerotherapy plus minus embolization followed by surgery. Now what are the advantages? It is a multi-pronged attack. Sclerosant will help to shrink the nidus. Nidus is the nucleus of the lesion. Our aim is to excise the nidus. So once the nidus is gone, the lesion is also gone. So the sclerosants help to shrink the nidus. Embolization knocks off the vascularity. Whatever feeding it is getting from the feeders, the embolization knocks it off. And then what all is left? Surgery removes the remaining lesion. So surgery is the finishing act in these things. So if we do a multi-pronged attack, it is very useful, especially for difficult vascular malformations. It is a preferred approach for difficult vascular malformations. Now here I have a clinical picture of a 45-year-old female showing a fleshy, pulsatile, palatal vascular malformation. You can see here, the lesion is here. If you see carefully, this palate is normal. Left side, this is a little congested. This is also okay. But in this area on the right side and in the retromolar area, there is this large fleshy lesion here. And it is extending into the pterygopalatine region and into the infratemporal fossa. So this lesion is difficult to handle by only surgical methods, because if I were to just go and excise it, and it has got, it is depthless, there is no depth. So if it starts bleeding, I won't have any option to arrest the bleeding. So therefore, multimodal treatment is good for these type of lesions. This is the post-treatment appearance following 3 sessions of bleomycin, coiling and surgical excision. Lesion has almost vanished with the treatment. If you see here, nothing. I've done 3 sessions of bleomycin, coiling and 2 sessions of surgical excision. Everything done aggressively and the lesion is gone. The lesion is gone. There is no cosmetic. It's just vanished. Kept on follow-ups to see for any recurrence of the lesion, and even if there is a recurrence, we monitor the recurrence by doing MRI and see where the recurrence is. But recurrence is a easier problem to solve than the primary lesion, because even if there is a recurrence, we can just go into that area and by targeted Doppler ultrasound, we can just put sclerotherapy right into that particular area. So this is the comparison of pre and post multinodal treatment appearance. You can see here before and after. I have another patient here. This is a clinical picture of a 39-year-old male showing a fleshy pulsatile palatal vascular malformation extending into pterygopalatine region and the infratemporal fossa on the right side. Again here, why there are so many lesions occurring here is a subject of research. Again, in this area, extending into the pterygopalatine region, infratemporal area. And this is the result after 3 sessions of multimodal approach and surgical excision. The lesion has regressed significantly in this patient. I'll not say that the lesion has almost vanished, but we have been able to control the lesion quite well. And further sittings of bleomycin or any other sclerotherapy will further help this patient. Now here is another patient. She's 45-year-old female, and in the front view you don't see the lesion much, but she shows multiple lesions of venous type of vascular malformation which involves the palate. The lesion is inside her palate, the lesion is in the lips, the lesion is in the cheeks, and she has been treated by combined modality of bleomycin, coiling and sequential surgical excision. Not one surgical excision but many surgical excisions. You can see the lesion here. Everything is blue here, just like a cobra, snake or venoms. Everything, the mucosa is so much involved, it is lost its red color, it is bluish. And these are lesions in the mucosa. This is the result after just 2 sessions of intralesional bleomycin, coiling and surgical therapy. This is the preoperative. You can see here the entire retromolar trigone, the palatal area, the teeth, the cheek area, they're all blue here. And with this bleomycin, the normal red color of the cheek is now being restored in areas which are still patchy. The lesion is quite extensive and she will need further treatments, but she has shown a good response to this multimodal therapy. I'm still afraid to go in and operate her surgically because of bleeding and everything, and I'll still put her on these methods, maybe some more coiling and more sclerotherapy before I'll undertake surgery for definitive elimination or ablation of the lesion for this patient. And this you can see here, this is not 2, this is 4 or 5 sessions here. You can see here, this was what she was before. Everything is bluish here, and if you see this picture after 5 sessions of bleomycin, coiling and surgical therapy, the lesion is at the most 10 to 15%. The entire blueness and everything is gone. The rest of the lesions on the lip and on the cheek mucosa I have excised surgically after getting bleomycin therapy. She's had 2 to 3 treatments of surgical excision and so many sessions of bleomycin, coiling and surgical therapy. Same patient, before and after, you can see. Here is another patient. We have been treating these lesions since 5 and 6 years. I've been here in this institute, and initially the patients were coming, but now with more results, more and more patients are coming to our OPDs, and most of these patients, they come with very difficult, neglected, and very large vascular malformations. And this is a young girl, and if you see here, the entire face is normal, but if you see the left ear is normal, but if you see the right ear, the whole right ear is involved with this vascular malformation. This is the posterior surface of the ear. You can see here the normal ear is gone. It's all involved in this vascular malformation, and she has a history of frequent bleeding from this vascular malformation, and this is a very angry looking type of a vascular malformation. You can see here. Now this patient was again put on this multimodal treatment. Combined intravascular coiling with immediate surgical ablation was done for this patient, for this girl. So what did we achieve? This was the before surgery appearance, and you can't just go in and excise it, because if you excise it, it's going to bleed very much. So therefore she had a lot of sessions of bleomycin, and after bleomycin I was wanting to preserve the cartilages of the ear, but that could not be possible because of the extensive lesion also inside the cartilages of the ear. So I had to excise the cartilages. So this is what is now left for her, and now this is the lesion after, and this is the picture after complete elimination of the lesion almost. It may be here in some areas, but there is a complete excision and ablation of the lesion, and she is left with this ear. And this ear is very easy for us to reconstruct, because this is what we do all day, reconstructing partial and total defects of the ear. So from this stage she has gone to this stage, and then I've done a ear reconstruction for her, which I'm not going to show here because this is not relevant to the topic. So this is for this girl here, combined intravascular coiling plus immediate surgical ablation. Now you see this lady here, and if you see here, she's got a lesion here. She's got a lesion on the forehead, not a big lesion. I'll just finish very fast. Yeah, it's not a big lesion. It's not a big lesion, but as I said, the vascular malformation, they cause aesthetic problems. So she had an aesthetic problem here, and she was bothered. Whenever she used to bend down, she used to have heaviness in the head, headaches and everything. So therefore she came for treatment of this lesion. And what I have done is, again, and this is the result after surgery here. You can see here, the lesion is almost gone after intravascular coiling and immediate surgical ablation. Here's another patient, lesion on the left side, you can see here. And this is the result after same combined sclerotherapy, immediate surgical ablation. This is the patient in the lateral view, before and after. You can see the difference. Here's another patient with a lesion again of the palate, same place, same area. And this is the result after coiling with immediate surgical ablation. You can see here the lesion is gone, before and after. I think this is probably the last but one patient. This is a patient with hemangioma. You can see here, I just was talking about hemangioma. This is a large lip hemangioma, huge. And these are the preoperative pictures here. And I've done a multimodality treatment. And this is the result after a few sessions of bleomycin and surgical excision. From this, we have gone to this. And again, the lesion is there. And from this, we have gone to this for this little child. Multimodality treatment for her. These are the results in the basal view. You can see here. Last but one patient, again the lesion in the lip here. These are the pictures. 2007, undergoing treatment, bleomycin, surgery, coiling. 2009, 2007, 2008, 2000. You can see the result after. This is the result in the intraoral view. You can see how the lesion has regressed after this combined multimodality treatment. The years are not right actually. It's not 2009. The years are not right. And this is probably the last patient here. Again, a difficult vascular malformation on the right side, deforming everything, face and everything, involving the pterygopalatine fossa, lips. Again, combined multimodality treatment here. After a few sessions, from this to this and from this to this, everything has shrunken and gone out of place. So I will like to just stop. Complications of combined approach, it's a new area. Not much in the literature is there. There is a greater incidence of complications. I have observed more flap ischemia, flap necrosis, and even graft loss. There are other complications of vascular malformations, which I will not go into the detail. Complications of treatment, they are the general complications. I'd like to conclude by saying that treatment of vasoformative tumors represents a challenge, and combined multimodality treatment has changed the management of difficult and refractory vascular malformations, especially if they are large in size and occur in surgically inaccessible locations. The surgical ablation must be performed immediately after therapeutic embolization for best results. Thank you.